Good
Hi,
morning, good afternoon, good evening, everyone. Just giving everyone a few minutes to join. We will get started shortly on our event today, marking UHC Day 2022. UHC Day, as you know, is just around the corner on Monday, 12th December. Before introductions, just a few announcements. On your Zoom screen, you should find a globe icon labeled interpretation to select your language channel. We will have simultaneous interpretation in English, French, and Spanish. Recommend that if you are an English speaker to select English and your desired languages, as we will have a panelist speak in French, a panelist present in Spanish, and the rest of our speakers will be presenting in English. There's also closed captioning available with the CC icon highlighted here in yellow. In case the Zoom platform is giving you trouble, as it has been doing recently, feel free to use the stream text link. We will put this in the chat box. You can access the closed captions in a different browser. Please use the chat box to introduce yourself and ask questions throughout the event. We will have a Q&A towards the end of the event, and we'll also follow up in case of time constraints. Now for introductions, my name is Karthi Manikarot, and I'm the Communications Officer at the CSEM, co-hosted by Waki Health, a regional advocacy organization based in Africa. I have the CSEM is the civil society constituency of UHC 2030, the global platform to strengthen health systems for universal health coverage. We have with us here today Akihiro Watabe from the UHC 2030 core team, who will be presenting the State of the UHC Commitment Review, an accountability tool that tracks progress on universal health coverage at the country level. Within the State of the UHC Commitment, we will be discussing the country consultations, which were a way to get insights from civil society and communities on the ground. From the CSEM Secretariat, Waisman Ikwanga will be presenting about UHC Day and other advocacy opportunities in the lead up to the UN high-level meeting on UHC in 2023. The bulk of today's session will focus on the country consultations themselves. We will have Jennifer Ho from UPCASO and also the CSEM advisory group present more details about what the country consultations are and how they were held. She will also be moderating this panel of our wonderful speakers who have led the country consultations this year. We have speakers from Uruguay, Singapore, Mali, Ghana, and Botswana, and you will hear more about them from Jen. We will then go to Lasha Gogadse from the International Federation of the Red Cross and Red Crescent Societies, who has been a key part of the global planning team since the consultations began in 2020. And of course, this is just a subset of the many key findings that were released this year with the CSEM's country consultations. This cannot be possible without our wonderful country partners who you can see on the screen. And we will have more of these events in the next few months where different partners will be presenting key findings from the country consultations and how they have been using it. The global summary is now on the website at cscmonline.net, and throughout UHC Day, there will be more opportunities to hear more about the report and some of the key findings that came from civil society and communities. Finally, before passing it on, just wanted to take a quick note to acknowledge why we are here today. What is universal health coverage, or UHC? While it is often seen as a very technical concept, which then limits who can engage on it and how, we believe that at the core of it, it has quite a simple definition. UHC is the global goal or the aspiration that all people can obtain the health services they need of good quality without suffering financial hardship. Health systems must be made more equitable, more accessible, and more affordable. And we will hear today from civil society and communities on how best they think that can be achieved for this global goal. It is my pleasure now to welcome our first presenter, Dr. Akihiro Watabe from the UHC 2030 core team. Dr. Watabe leads many of UHC 2030's political work and advocacy work, including the UN Universal Health Coverage Political Advisory Panel, the UN High-Level Meeting on UHC in 2019, the Campaign for International UHC Day, and the State of the UHC Commitment Review. Dr. Watabe, please feel free to begin when you're ready and share your screen. Thank you.
Yeah. Thank you very much, Kathy. Thank you everyone for joining this session. So let me share my screen. Second. So today, I'd like to briefly explain the state of US commitment work that the UHC 2030 started 2020 with the civil society and other multi-stakeholder partners. So this is the multi-stakeholder review of the state of UHC commitment, based on the 2019 UHC political declaration. And we set the simple question, the countries acting on their commitments toward universal coverage in the different dimensions of universal health coverage, and also the key commitments made in the 2019 political declaration. And WHO, World Bank, and other UN agencies, they tracking the UHC indicators on service coverage and financial protection. That is more quantitative data that they regularly monitoring the data every 2 years, and they expect to publish a new data. But our review is more focused on political and also country focused, and some actions oriented too that the civil societies and the partner can use for the advocacy and accountability activities on the ground. So far that the UHC 2030 published 2 reports in 2020 and the 2021 as a part of the synthesis of the review. And also we published the country profiles across countries in 2020, and we keep updating the progress of the commitments. So the last 2 years, we review around 139 UN member states, which is around 72% of the member states of the UN, to update the country profile in line with the political declaration, the commitment indicators. We expect the new findings available for the country the multi-stakeholder consultation for the UN High-Level Meeting starting early January. But I'd like to share some key findings in the session today. So first of all, the country profile that we launched this week, the new data that's already available on our UHC data portal that you can scan this the QR code or just Google UHC data portal, and you can find the country profile across 139 countries in the overview of the UHC commitment progress, and also the level of the implementation, and also some data visualization based on the UN statistics, and also you can compare some institutional efforts of the country to implement the country implementation of the UHC commitments across countries. And also we use some the third-party data, especially the data produced by civil society networks on the budget, the Open Budget Index, Corruption Index, or civics space rating. And also we use the media monitoring to collect some of the public perception of universal coverage. So in terms of the overall trend that we see that the more number of countries expressing the commitment toward universal coverage per year, and almost double the number of the expressed commitments, and also increasing number of countries to make a commitment, and also total number of commitments. That is the more than double. And however, in 2022, that we see that this positive trend dropped down and even reversed after 2 years increase of the commitments. And we also see similar trends after the SDG 2015, that some good increase of the commitments and then drop. So we see that we need some political, the global level, the political momentum generation to maintain the reporting and also generate the commitment the country over time. And also many country commitments are fragmented, that you see that many commitments are made, but still they focus on the very specific disease agenda or service-specific agenda, although they claim they are part of the USD, but not comprehensive enough. And also many commitments are part of the service coverage package or services or population coverage to cover more general, more population, different groups, but not much on the financial protection side. So service coverage is around 44% of the commitment, and population coverage is around 43%. However, only 13% cover the financial risk protection dimension for the commitments. So there are systematic under prioritization and investment in reducing the financial barrier to healthcare according to the commitment. The next slide. So we analyzed the commitment in line with the 8 commitment areas of universal coverage, which are the ensuring political leadership, leave no one behind, regulate, legislate, and uphold quality of care, invest more, invest better, moving together, and the gender equality and emergency preparedness. And so these are the key top line messages that we can share today, but the more detailed findings and also data will be available early January. And I'd like to highlight the 3 points in the presentation today. That the first of all, the leave no one behind. The vulnerable groups continue to face financial barriers, access to health services, and the commodity they need. That is the one finding we identify on the equity dimension. And then also in terms of the invest more, invest better. As you may know that today WHO will release the new data on the expenditure, health expenditure tracking. But despite the continued increase in overall health spending in 2020, which is the latest data available, due to the COVID-19 response, so more country government spend more money for health through the government the budget, but still the current government investment is not enough and not adequate to achieve universal coverage to protect the financial barrier for the patients and their family. And also in terms of the moving together and the accountability element, the limited number of countries have a formal or effective functional accountability mechanism for universal coverage, and also with inadequate engagement of non-state actors, including civil society. So we are happy to share more details early January, but all the findings are also based on the civil society country consultation. And thank you for all your efforts to analyze the findings and also support our work. Thank you very much. And over to you, Jessie.
Thank you so much, Akihiro. It was great to see some of the preliminary findings. We look forward to seeing the full synthesis in January and using the data portal more in the coming months. Next, I would like to welcome Jennifer Ho, from the Deputy Director of APCASO, and who's also an advisory group member of the CSCM. APCASO is a regional civil society network of community-based and non-governmental organizations working on health, human rights, and social justice in Asia and the Pacific. Jennifer is a feminist and a global health advocate with more than 20 years of experience in working with and advocating for the rights of vulnerable and marginalized communities in Asia and Pacific. It was great to have the support of APCASO for the country consultations in the last 2 years. Looking forward to hearing more from you today, Jen. Thank you.
Thanks, Karthi. And thanks again also to CSAM for the opportunity. Very important discussion and sharing. Karthi, can we start? Great, thank you. Apologies for a technical challenge right now. But once again, thanks to CSAM and the team for the opportunity to be part of this really important discussion and sharing. And again, on behalf of the CSAM advisory group, much appreciation to all the participants who have taken their time to join us for this discussion today as well. So I do have a set of slides for sharing, but while Karthi is trying to help me figure that out, just let me give a little bit more background on the country consultation. I know that we just heard from Dr. Akihito about the global framework and the tools for UHC, including the state of the UHC commitment report. What's really important to note that the perspective and experience of communities and civil society form a really critical part of how we monitor our progress toward UHC and how we hold our governments accountable for the commitments that they have made towards UHC. So in 2020, the Civil Society Engagement Mechanism for UHC 2030, also known as CSAM, started supporting a series of civil society consultation globally with the aim of gathering and documenting the experience of communities and civil society around the world on their experience about UHC. These civil society consultations are grounded in our shared belief that the true measure of UHC is to what extent a country's most vulnerable and marginalized populations have access to and are able to benefit from healthcare services that address their specific health needs without undue financial or any other types of burden or distress. Because to truly leave no one behind, we must put those who are often last first, for they are the very people UHC is meant to reach. Karthi, thank you so much for that. So the findings, so we can stay on this slide for now. The findings from these civil society consultations are synthesized, as you heard earlier, and integrated into the UHC commitment reports. And they are also published separately as an additional and complementary accountability tracking tool. Next slide, please. So briefly about the methodology before we move into our panel discussion and sharing and hearing a little bit more of the details from the country consultation. Overall, at least one, if not more, focus group discussions were carried out in each of the focus countries. These focus group discussions were carried out using a set of the standardized questions developed based on the key asks from the UHC reports that form part of the State of the UHC Commitment Report. Participants of these focus group discussions included members of marginalized communities, such as people with disabilities, migrants, refugees, the elderly, LGBTQI+, the ethnic minorities, as well as, depending on the country context, like who are these additional marginalized communities that need to be considered. These discussions also included women and girls, adolescents and young people, local community members and leaders, and civil society advocates working on health. So it is also very important, I think, if anything, that all of these focus group discussions were led and facilitated by community and civil society members. Next slide, please. Today, a total of 36 country-based consultations and 1 regional consultation have taken place between 2021 and 2022. And earlier, Karthi shared a little bit clear, detailed breakdown of what these countries are. But you can again see the names of the countries by region on this slide. Next slide, please. So as mentioned, findings from these civil society consultations are synthesized and included not just in the Global UHC Commitment Report. They're also published separately by CSAM and partners, including APCASO, where we have been putting out individual country summary sheets and also a regional report as well based on a consolidated finding. And again, they are meant to serve as an additional complementary accountability tracking tool. And many of our partners have actually taken on their own initiative, sharing these reports from the country to their Ministry of Health as they prepare for next year's high-level meeting on UHC, which you'll hear a little bit more about later. So let me now move into our panel discussion with country partners, so you can hear a little bit more about, their key findings. And as mentioned earlier, we have invited partners from Uruguay, Singapore, Mali, Ghana, and Botswana to join the session today and share with us their key findings and some of the key recommendations from their respective consultation. So let me first invite, and again, please make sure you have your interpretation function on the correct set. Let me first invite Diego Rodriguez from Uruguay to speak. Diego is a marketing analyst and professor at the University of Republic. His research focuses on topics of the social area, health sociology, and evaluation of tobacco control policies. He's a member of the CIET and the NCD Alliance Uruguay. In the CIET, he is a representative in a working group on human rights and transnational companies of the National Institute of Human Rights. He's also a member of the Advisory Commission for Tobacco Control. So what we have asked Diego to share with us a little bit about was that Uruguay has UHC policies based on the right to health. However, the focus group report noted that there are still gaps, including populations and communities being left behind. Can you share with us a little bit about, Diego, that who are these populations and communities, and how can we better hold policymakers accountable to ensure that these populations and communities' right to health are being upheld and protected? And again, welcome for joining, and thanks for joining us today for the session. Over to you, Diego.
Buen día, muchas gracias por la invitación. Espero ser claro, voy a hablar en español. Bueno, en primer lugar, agradecidos también por el apoyo de la comunidad de UHC 2030 por el poder haber relevado la opinión de la sociedad civil respecto de cómo funciona nuestra cobertura universal de salud. Es bueno recordar que Uruguay, la cobertura universal de salud está consagrada en diferentes leyes o normativas, pero lo que se termina observando a partir de la experiencia de algunas personas vinculadas a sociedad civil es que esta cobertura termina teniendo sus dificultades en realidad. Y ahí tenemos, quizás para diferenciar, dos tipos de dificultades. Una es de acceso y otra es de calidad. En cuanto a calidad, y bueno, un poco también afectados por la pandemia, pero en el post-pandemia, o por decir una forma, post-pandemia, lo que ha sucedido es que tenemos los tiempos de espera para poder acceder a la atención médica, no es igual para todas las personas, incluso son tiempos bastante elevados para algunas enfermedades en particular las enfermedades no transmisibles, como por ejemplo cáncer, diabetes, bueno, diferentes enfermedades que muchas veces para acceder a un especialista se requiere mucho tiempo para poder ser atendido. Por otro lado, también estamos teniendo dificultad de acceso a los medicamentos, e incluso a Uruguay, no solo el acceso, sino también qué tipo de medicamento y la calidad de ellos, ¿no? O sea, hay medicamentos de mejor calidad que quizás accede cierta parte de la población, pero hay otra parte de la población que accede a medicamentos de menor calidad cuando logra acceder. Por otra parte, también tenemos, en cuanto al acceso, hay diferencias en las diferentes subpoblaciones de acuerdo a lo que pudimos ver en el relevamiento. Y ahí podemos hablar de lo que son las personas trans, por ejemplo, las personas afrodescendientes, pero también tenemos unas dificultades en el Uruguay en cuanto a la ubicación geográfica de donde reside la persona. Y en este sentido, Uruguay ha sido un país que históricamente se construyó desde la capital hacia el resto del país, muy centralista, muy capitalista, muy centrado en la capital, pero lo que pasa es que quienes viven alejados de la capital tienen diferencias en el acceso a los servicios de salud, incluso a la calidad de los mismos. Muchas veces requieren trasladarse a la capital, y no todos tienen la posibilidad, no solo la capital de Uruguay, sino que a veces también en las capitales de las diferentes regiones. Y eso plantea dificultades de seguimientos de atención, personas que requieren un control continuo a veces no asisten, incluso porque no pueden llegar. Y esas son cuestiones que hoy en día estamos necesitando solucionar en esta cobertura, en este compromiso de cobertura universal de salud. Últimamente también se ha dado que hay personas que tienen acceso VIP, o sea, acceso preferencial, dependiendo de si uno puede pagar mayores costos en acceder a cierta atención de calidad o a ciertos estudios para ser evaluada su situación. Eso es algo también que está marcando una gran diferencia en Uruguay. Y de acá me voy a ir hacia lo que es la participación de la sociedad civil, que también surgió de este relevamiento, donde quedó en evidencia que todas estas problemáticas, que las podemos descubrir a partir de la consulta con la sociedad civil y con organizaciones de pacientes, bueno, desde el lado del Estado, del gobierno, no se está logrando, por lo menos, escuchar a la sociedad civil, dado que incluso eliminaron un ámbito de participación consagrado en la ley, que es la JUNASA, la Junta Nacional de Salud, donde la sociedad civil y los pacientes tenían participación. Esto lleva a que no hay un ámbito de diálogo, incluso desde la sociedad civil hemos solicitado participar, no solo retomar la participación en este ámbito de discusión, sino que también en otras comisiones que tratan específicamente algunas problemáticas vinculadas a enfermedades no transmisibles, vinculadas a obesidad y sobrepeso. Incluso a nivel exterior el gobierno se compromete a ciertos planes pilotos que no terminamos de conocer a la interna en Uruguay, la sociedad civil, y por lo tanto no terminamos siendo escuchados ni como sociedad civil ni como pacientes, cuando somos las personas que realmente o somos usuarios del sistema y experimentamos las dificultades que habría que superar, o somos las personas afectadas por ciertas enfermedades que necesitamos atender. En ese sentido, desde la sociedad civil hemos solicitado continuamente un ámbito de diálogo, quizás más abarcativo, a lo cual nosotros le intentamos denominar el Foro Nacional de Salud, un ámbito donde se pueda discutir con todos los actores, con quienes prestan los servicios de salud, con el Estado en su rol de policía sanitaria, pero también como el garantizar esta cobertura, y también la sociedad civil como quienes somos usuarios y quienes necesitamos esa atención de calidad y de acceso para todos, como dice el lema, ¿no? Para no dejar a nadie atrás. Por otro lado, es importante rescatar que estos ámbitos en los cuales se está pidiendo participación son ámbitos de diálogo, ¿no? Ámbitos de diálogo que lo que pueden hacer es beneficiar tanto en el diseño de la política, en la evaluación de la política, e incluso en la fiscalización del cumplimiento. Porque justamente podemos tener, como está pasando en Uruguay, quizás podemos tener muy buenas leyes, pero si las leyes no son fiscalizadas, eso puede llevar a que en la práctica no se terminan aplicando. Y el rol fundamental también de la sociedad civil, además de participar en estos ámbitos de discusión y aportar apoyo, porque muchas veces la sociedad civil apoya a las personas que están padeciendo ciertas enfermedades en atender cuestiones extrasistemas de salud, ¿no? Por ejemplo, hay personas migrantes que tienen dificultades de acceso, que lo que hace la sociedad civil a veces es facilitarle un trámite para que pueda acceder a la ciudadanía, o para que pueda acceder a un papel que le permita atenderse en el sistema de salud, y eso el Estado no lo está viendo, no lo está solucionando, y ahí siempre está la sociedad civil para poder dar este marco de apoyo para poder acceder al sistema. Por otro lado, también desde la fiscalización hemos aportado, pero una vez que la sociedad civil, por ejemplo, hace un relevamiento desde el lado de la fiscalización, cuando se le presenta al Estado, lo que no recibimos como de la contraparte es qué se hizo con esa fiscalización que se presentó, y por otro lado, no vemos cambios una vez que la sociedad civil presenta estas situaciones que a veces son bastante problemáticas. Y por último, quizás, un rol importante de la sociedad civil es visibilizar los problemas, y por eso el compromiso que tenemos que tener todos con estos temas de poder visibilizar la problemática del acceso a los sistemas de salud, pero la problemática de la calidad también de atención. Porque los muchas veces, una vez un político me dijo que a veces ellos no podían tomar decisiones por 3 motivos. Uno es porque no sabían, otra es porque no podían, y otra es porque no querían. Nosotros creemos que desde la sociedad civil, nosotros tenemos que evitar el no sabían, y eso implica hacer conocer las situaciones, hacer conocer las leyes, hacer conocer las normativas, pero también hacer conocer las propuestas que nosotros desde nuestra perspectiva creemos que se pueden llevar adelante. Y también en el caso, bueno, en Uruguay sucede en algunos casos extremos donde no hay respuesta.
Diego.
Okay.
May I stop you here for a pause
Sí, okay.
as well?
Simplemente
Just because
terminar con esto.
I mean,
cuando las soluciones no vienen por estos ámbitos.
You've just painted a very sobering picture of the situation of both the users, the patients, but also, you know, the lack of space for civil society to engage with the government on improving the situation. And I'm actually want to put UHC 2030 on the spot, given that there's going to be a high-level meeting next year, and I'm hoping through today and as we continue the dialogue for the next hour or so, that we'll be able to find a way and a strategy to support civil society group in Uruguay and other similar contexts for better engagement as well. But thank you so much for sharing the findings and the reality of the situation in Uruguay. I'd like to move to turn the floor to our next panelist from Singapore. So I think contrary to Uruguay, where it's a less developing country, that we tend to think high income country like Singapore, the situation might be a little bit better. So we thought it might be interesting, and it would be interesting to invite our 2 lead researcher or the lead focus group discussion leaders from Singapore to share with us a little bit of the findings from Singapore and a little bit of a situation of Singapore as well. So let me invite Nikita Hanumuri Mandam and also Capuchin Barcelona to join us today. And I'm really sorry I'm butchering your name, so please feel free to correct me or repeat your name again for me. But I think Nikita, you'll be the first one speaking, correct? So Nikita is a global health researcher at the Leadership Institute for Global Health Transformation in the South Wu Hock School of Public Health in the National University of Singapore. Her interest lies in digital health and health system strengthening in countries across Asia. Prior to this, Nikita completed her undergrad study in biology and business at the Nanyang Technological University in Singapore. So Nikita, my question for you today is from the perspective of your focus group participants, what do they consider as one or two key achievements of Singapore's UHC policy and implementations? And what are the gaps specifically? Is there any particular population or communities being left behind, and how are they being left behind? Earlier, we heard about, patients not being able to access healthcare. They are not able to have a choice of the kind of healthcare they want to have, and there are also concerns about quality of healthcare. Can you share a little bit of the Singapore experience with us? Thanks, over to you.
Yeah, sure, I'd be happy to, and thanks for having me and Kapu here. It's great to be here. Let me just share my screen. I think we have a key slide that we've prepared for this. Yeah. So yeah, I'll cover this first question. So in terms of the achievements, most of the participants from our consultation stated that the overall quality of care in Singapore is pretty high. There's access to a lot of different specialist services, and we're also starting to leverage a lot on digital health technologies to make care more personalized. There's also this huge shift towards transforming the system from being curative to actually preventive. So we have a National Health Promotion Board as well, which focuses on rolling out national wellness programs and things like that. So the overall quality of care was rated to be pretty high in Singapore, but there definitely still are gaps. And while while healthcare is pretty good for the masses, and this includes Singapore citizens and permanent residents, for communities which don't fall within the majority, there's definitely gaps. And these communities include many of the communities that you've already stated, such as the LGBTQI+ group, people with disabilities, mental health issues, those who are economically disadvantaged, foreigners, as well as those who are in this sandwich income status, meaning they're not rich enough to afford the services, and they're also not poor enough to be eligible for subsidies. So see, these are some of the marginalized communities within Singapore. And they sort of experience gaps across all three elements of UHC, so access, quality, and cost gaps. So for example, in terms of access, there's no HIV program tailored towards the transgender population. They're actually asked to just piggyback off the HIV program for other genders. So in terms of access, that's one example. In terms of quality, one of the things that a lot of the participants brought up was that there isn't a focus on patient experience, and that the human element is sort of missing in Singapore's healthcare. So the doctors need to be more trained in how to deal with patients who have special needs. And they shouldn't only, think about what is the matter with the patient, but also, what matters to the patient. Yeah, so, and for cost, one of the examples was among the migrant worker populations. So their healthcare is largely tied to their employer and how much the employer is willing to pay for them. So migrant workers actually have a lot of financial barriers in accessing care. And a lot of times we unfortunately see that they're actually repatriated back to their home countries where they receive care over there. So that's a quick snapshot of some of the gaps in Singapore's healthcare. And I thought I'd end off with this one quote at the bottom on the left, which one of the participants shared, which is, how do we start to think about customizing the system to fit the people instead of the other way around? And I'll end there. Thanks.
Thank you so much, Nikita. And I think that's a really pertinent point to make, right? As we continue to think about how we evolve the conversation around UHC and to make it accessible for all. So let me turn the floor over to Kabul. Kabul team Barcelona, it's a global health researcher at the Leadership Institute for Global Health Transformation, Salsay Hawk School of Public Health, National University of Singapore as well. Her current work focuses on health system, health equity, and digital health in Southeast Asia. Her research interests also include mental health, gender, and health promotion for vulnerable communities. And she holds a Bachelor's of Art in Honor in Anthropology and Literature from Yale and US College National University of Singapore. So, Kabul, following Nikita's sharing, my question to you then, what contributes to these populations and communities being left behind? What specific elements and factors that cause their increased vulnerability, their lack of ability to access healthcare equity, and what are some of the key policy changes that need to happen that came out from your focus group recommendation that we need to make in order to bring Singapore's UHC policy to become more inclusive and responsive to the needs of these population and communities. Kabul, over to you.
Yes, thank you so much, Jen. Thank you for the opportunity to speak. So I'll just pick up on what Nikita has already mentioned. I'll actually talk about 3 points as to what contributes to these populations being left behind, as well as on the same points, what policy changes can happen in order to make Singapore's UHC policy more inclusive. So first of all, the decision-making culture in Singapore, including on the health system, is largely top-down from the government. So in health, for example, there's no dedicated agency to oversee UHC or to engage communities on the ground. There have been consultations open to the public, whereas other consultations have been done behind closed doors on specific health issues. So for example, I believe last year, there was a consultation as to whether to allow Muslim nurses to wear tudungs or headscarves at work. And this was held behind closed doors because it was a so-called sensitive topic, but justification is not always given as to why a certain consultation is held behind closed doors or open to the general public. So there's certain communities that are especially shut out of this decision-making, such as non-local residents, so people who are not citizens or permanent residents in Singapore, as well as stigmatized communities, such as, for example, sex workers, sometimes LGBTQ communities. So an example is that sometimes organizations catering to marginalized communities, like for substance rehabilitation, are asked to either do advocacy work or to provide community resources and services. So this creates a bit of a gap in the advocacy that the communities can do in terms of advocating for their health. So finally, another issue in terms of decision-making is that when communities are consulted, it's not always clear what the result of these consultations are or why a certain change took place. So as you can see from a participant quote here, that after sitting in a lot of discussions, is there an endpoint? The change happened because of these talks. So the second point in terms of why communities are left behind is that some aspects of health in Singapore are still heavily stigmatized, including mental health issues. Suicide was criminalized until 2019 here, and substance abuse, where Singapore has very strict drug laws. So substance abuse is seen as a moral failing rather than a public health issue. Even within the medical field, patients can encounter stigma if they belong to certain identities, such as LGBTQ patients. And this is partly due to a lack of education among medical practitioners on the need of vulnerable communities, such as assigning the proper pronouns to their trans patients. Finally, another point as to why communities are left behind is that Singapore places a high emphasis on efficiency of its health system, and it is indeed ranked as one of the most efficient health systems in the world. So there are performance indicators to be met in terms of the length of hospital stays, the number of patient visits. However, Singapore does have a lower number of health staff as compared to similar economies, and this can contribute to a lack of patient-centric care and feelings that consultations are very rushed. So as a participant indicated, sometimes doctors must cover a lot of patients in a short amount of time, and consultations cannot really go above 10 minutes. So this is a bit hard to cater to the needs of marginalized communities with specific health needs. So finally, in terms of policy changes that need to happen in order to make Singapore's UHC policy more inclusive. Number one, back to the first point, is that there's a need to have more community involvement in decisions in the health system. So civil society organizations should be consulted for more issues and include groups that are traditionally overlooked, such as sex workers and LGBTQ populations. So a sentiment that came up during our focus group discussion was that there should be nothing about us without us. So don't do anything for us without asking. Do not assume our needs. Secondly, there should be an effort to reduce stigma and discrimination, perhaps considering harm reduction approaches to issues like substance use. But for this to happen, deeper social structures and values in Singapore will need to shift in order to destigmatize, for example, LGBTQ populations and HIV positive status, drug use. Finally, there's a need to improve human resources for health to deliver better patient experiences and cater to specialized health needs. So this might include allowing foreign nurses to settle down permanently in Singapore. Sometimes Singapore is just a stepping stone to destinations such as the UK or Australia, giving fair compensation, especially in the private sector, to reduce attrition fair compensation in the public sector to reduce attrition to the private sector. And finally, ensuring that health staff are also cared for and not burnt out so that they can provide better care and pay special attention to vulnerable populations and be trained in catering to their health needs.
Great. Thank you so much, Papu and Nikita, for the sharing from Singapore. And I think that there are some really important points for us to take note as well, but I won't summarize those in the interest of time. Just before we move on to the next panelist, I just want to say that for participants to please leave your questions, comments, reactions in the chat box. We'll have a chance later on to come back to your questions as well. And also for the panelists, to please check back on the chat to see if there are any questions specifically directly at you. And if you could please help respond to those in the chat, that would be helpful as well. I'm going to travel around the world and take us next to Mali with our next speaker, Namusa Seganonga from Mali, who holds several other positions, including a position as the permanent technical secretary of the NGO Network and Association for Action Against AIDS in Mali. He's also a member of the ICM. I think that's the CCM for the Global Fund in Mali, and the focal point of the support mechanism for organizations of civil society in Mali as well. Musa, but my question for you today is, can you share one success story of civil society and community engagement in health that came out from your focus group discussions? And what are some of the key factors that contributed to the success, relating to engagements specifically? Can you then also speak a little bit more about how the government in Mali engages civil society? Because earlier we heard about in Moulakwe that there are challenges around civil society engagement with policymakers as well. And before I turn the floor to you, kind request to please keep your response succinct and to about 5 to 6 minutes if possible. Thank you. Over to you.
Ok, merci bien, madame, de me donner la parole, de me donner l'opportunité de m'exprimer par rapport à la couverture sanitaire universelle. Donc, pour revenir à la question, c'est que le Mali est un vaste pays de 1 241 000 km². Donc, avec des organisations de la société civile très bien structurées, il y a au niveau du Mali, il y a les associations à la base, il y a les ONG, il y a les réseaux et les plateformes. Maintenant, compte tenu de la participation de la société civile au processus de la consultation, nous avons fait on a convoqué toutes les sensibilités des organisations de la société civile qui interviennent dans la santé. Donc, on a fait la consultation, partagé avec une ONG internationale qui est Chef Children, qui avait déjà lancé le processus pour la mise en place de la coalition des organisations de la société civile pour la couverture sanitaire universelle. Donc, on a travaillé dans ce processus. Donc, intervenant dans le cadre de la réussite de l'engagement de la société civile, je vais parler du cadre de la Fédération nationale des associations de santé communautaire. La FENASCOM, Fédération nationale des associations de santé communautaire, est créée en 1994. Elle regroupe les ASAPO. Les ASAPO, ce sont les associations de santé communautaire qui se trouvent au niveau commune, au niveau des quartiers et à la base. Maintenant, ces associations de santé communautaire sont dotées des infrastructures de santé communautaire. Donc, il y a à peu près en 2020, 1476 centres de santé communautaire qui sont fonctionnaires sur l'étendue du territoire. Et du point statistique, 55% des centres de santé communautaire, ceux qui font le paiement, c'est-à-dire le paquet minimum d'activité au niveau de la structure à moins de 5 km. Et le 88% font le paiement et paquet minimum d'activité à moins de 15 km. C'est pour vous dire que l'étendue du territoire est déjà occupée par les structures de santé pour le bien-être de la population. Maintenant, au niveau de la protection sociale, au Mali, il y a les instruments juridiques qui sont là. Tous les instruments juridiques sont fonctionnels au Mali par rapport à la protection sociale. Donc, au niveau de la protection sociale, il y a les lois pour l'adoption de l'assurance maladie universelle qui est adoptée le 31 décembre 2018. Il y a la stratégie nationale du financement de la couverture sanitaire universelle adoptée en juin 2018. Et le gouvernement a mis en place au niveau national l'Agence nationale d'assurance maladie qui doit mettre en œuvre la couverture sanitaire universelle au niveau du pays. Maintenant, cette structure agence a des relations très, très bien avancées avec les organisations de la société civile par rapport avec la FENASCOM. Donc, la FENASCOM qui a déjà représenté sur toute l'étendue du territoire s'occupe de l'identification des indigents dans les zones difficiles, ils participent aussi au paiement des prestations médicales fournies par les ASACO. Aussi, il y a la coopération entre les associations de santé communautaire à la base et les mutuelles de santé. Donc, c'est pour vous dire qu'il y a une certaine collaboration entre le pouvoir public et le pouvoir communautaire dans le cadre de la santé. Et les ASACO font les 70% des prestations de prise en charge médicale des membres des mutuelles. Donc, les mutuelles au niveau des ASACO vont être enregistrées au niveau des centres de santé pour quand même pour le paiement de leurs prestations. Et en plus, il y a un système de prise en charge collective des références d'évacuation vers les hôpitaux du district sanitaire par le biais des ASACO. Ça veut dire quoi? Toutes les communautés, c'est-à-dire que les associations participent à l'évacuation sanitaire des populations qui se trouvent au niveau de leur aire de santé. Donc, ça, c'est une solidarité collective qui est là et que tout le monde participe à ça. Mais malheureusement, il faut quand même revenir sur ça. Dans nos consultations, on a dit que malgré ces maillages du pays par les associations de santé communautaire, le problème se pose au niveau du financement de la santé. Le financement de la santé. C'est pour vous dire qu'au Mali, nous avons deux sortes de budgets. Il y a le budget d'État et le budget des collectivités. Maintenant, le budget des collectivités, ces deux budgets sont élaborés par les services techniques des collectivités et les services techniques de l'État. La société civile est fortement encouragée à participer à ce processus. Mais malheureusement, compte tenu de beaucoup de contextes, et la qualité de la prestation de la société civile est très minime. Parce que nous avons beaucoup d'insuffisances au niveau de notre participation au collecte et à l'identification de nos besoins d'avoir pu participer au budget. Ça, c'est un. Bon, ça se trouve au niveau de nos structures même. Il y a beaucoup de problèmes des personnes qui n'ont pas beaucoup de notions de processus budgétaire. Et puis, il y a beaucoup d'insuffisances dans la définition des priorités. Donc, le manque de collaboration entre nous-mêmes à la base pour quand même faire, parce que chaque aire de santé il va travailler dans sa zone pour que ses priorités soient dans le budget.
Moussa, can I ask you to move forward to responding to the second part of the questions, how the government works with the civil society?
Oui.
Because we do need to wrap up very quickly here as well. Thanks.
Allô? Oui, mais maintenant, le besoin de la préparation. Alors, je ne vous attends pas. Pour la conclusion, oui, à la conclusion, il s'agit vraiment de... Oui, à la conclusion, il s'agit que les centres de santé communautaires sont les premières références dans le système sanitaire malien. Cependant, ce système malien, à travers le centre de santé communautaire, sont confrontés à des manquements de ressources humaines, de qualité et de financement. C'est cette situation qui rend difficile les prestations de qualité de nos structures de santé pour atteindre de la couverture sanitaire universelle. C'est ça que je voulais en parler brièvement. Merci. Merci.
Thank you so much also, Moussa, and apologies for cutting into your time. We will make the slides available as well for participants who want to look into in further details. But thank you so much for that sharing. Definitely really interesting experience coming out from Mali. So let me then next invite Peter Yara from Ghana to share with us the experience from Ghana as well. So we know Peter. Peter is the Executive Director of Basic Needs Ghana. He's a development worker with 2 decades of experience and a leading mental health advocate in Ghana. He has dedicated his work to improve the lives of people living with mental health conditions, promoting community mental health services, and supporting inclusive programs and policies for health. He is also a member of the United for Global Mental Health Network. Welcome, Peter, and thank you for being with us today. So, Peter, we know that Basic Needs Ghana has already been conducting advocacy activities based on the issues raised through the focus group discussions, including concerns around gaps in the quality of care and exclusion of mental health services in UHC. So how are civil society and communities mobilizing to advance these issues? And how are the policymakers responding to these findings and requests from civil society and communities? Over to you, Peter.
Peter, you're on mute.
Oh, sorry about that. Very usual of these. Thank you very much, Jennifer and Asha, your colleague. And hello to fellow panelists and interpreters and participants. I'd like to thank United for Global Mental Health and WACI that made it possible for us to do the consultations, and for the UHC 2030 civil society engagement mechanism that gave us the opportunity. As you rightly said, the consultation was yet another opportunity to galvanize citizen voice to speak on issues of universal health coverage and where mental health sits. And what was established clearly was that there are still gaps in the quality of mental health care services provided. And mental health is very much missing in the universal health coverage efforts of Ghana. Yes, it is the case that Ghana has a universal health coverage strategy. Interestingly, mental health has only a mention and can be described as conspicuously missing. And as a result, the need for government to really re-look at the strategy it is using to address universal health coverage. For there is ample evidence that ignoring mental health would not lead to any country realizing universal health coverage. And the specifics of it are the fact that access to mental health and psychosocial support services still remain very difficult to the average person with a mental health care need. Yes, there is pronouncements that community-based care is the way to go, but there is still an overwhelming focus on supporting the three institutions with whatever funding that is there. And this is not helping the case to bring mental health closer to the people. Another clear example that was articulated in these consultations was mental health not being part of the National Health Insurance Scheme. However, just during around that time, we got news reports that the CEO of the National Health Insurance Scheme that had just taken over made a pronouncement that going forward, mental health was part of the National Health Insurance benefits package. But this has really not practicalized. So we are still where we are, where making mental health affordable and cost-effective and financing not being a barrier, not being achieved as part of universal health coverage. Participants also talked about poor integration in other global priorities and national priorities, such as treating and preventing HIV/AIDS and tuberculosis, as well as mental health being situated in sexual and reproductive health care, including services for young people. And this gap, surely, it's not one that will help Ghana realize the aspirations and targets of universal health coverage. But be that as it may, the report and the consultations and contacts that were done got a good response from policymakers. They thought that this is a captured civil society voice that needs to be factored into what needs done. And so granted access for feedback on the consultation processes and the findings that have been established from there. And so the expectation is that having embraced and accepted that the civil society voice of how to realize universal health coverage are necessary, now requires the next step of actually practicalizing that in documentation and in investments. And this is where in our part of the world, we get stuck. While there is agreement that this is a good move, these are very useful findings and recommendations, we do not really get the political commitment to see them through. And hence, Basic Needs use the opportunity of the 2020 World Mental Health Day to highlight on these. And we have continued to hold engagements with the National Health Insurance Scheme to get this done. There is growing interest and recognition that should be done. And the Mental Health Alliance, which Basic Needs leads, continues to focus on engaging with the Secretariat of the SDG Secretariat in Ghana that is responsible for the universal health coverage to ensure that inclusion of mental health and psychosocial support services really get realized. So thank you once again. I'm doing this on behalf of our civil society coalition, Mental Health Alliance, that very much were part of this. And there's several people with lived experience of mental health conditions that gave out voluntary support, continuing to emphasize that nothing about them without them. Thank you so much.
Thank you so much, Peter, and thank you for a really succinct response to the question as well. Let me invite our last panelist speaker from Botswana, Dumiso Kacha, who is a feminist human rights defender and founder of Success Capital NGO, an LGBTQI+ grassroots organization that helps young people navigate from survival to success. Dumi is also an advisory group members at CSAM and co-chair of the United for Global Mental Health Working Group. Through Success Capital and other groups, Dumi works to strengthen and safeguard LGBTIQ+ youth lived experience in public health, governance, and policy making. Welcome, Dumi, and thanks for joining us today. So my last question to you today for the panel is, how are the country civil society USC focus group discussion being linked to the volunteering national review process, also known as VNR process in Botswana, this continuing our conversation around advocacy. So what can we learn from your experience to strengthen government accountability, including development and implementation of accountability mechanism for USC commitment leading up and beyond the upcoming HLM on USC in 2023? And if you could keep your comments to 5 minutes, that would be much appreciated. Over to you, Dumi.
Thanks so much, Jennifer, and apologies, I have to do a bit of gymnastics with my technology just to make sure our power cuts don't impact my delivery. I think, context is very important. Botswana previously had not submitted at least twice for the voluntary national reviews. And so I think, this was quite a common trend in terms of foreign policy and its approaches towards international mechanisms as that, cut across with treaty body and special procedure commitments. However, I think, the fact that Botswana was or had the ECOSOC presidency, this obviously provided an opportunity for them to really ensure that there's full participation. So I just wanted to put that out there. And then just flag that, consultations really did provide, I think it's really more validation, because a lot of grassroots organizations are already working on a lot of these issues and have the understanding and do conduct participatory operational research or diagnostic research. And I think, being able to link this to, the global, state of the world, state of UHC report, and, sort of making sure that there are other jurisdictions that are doing similar sort of work around the understanding and ensuring that there is common knowledge, because I think there's always always an assumption when, we're consulting that, folks do have an understanding of UHC, and that isn't necessarily always the case. Also acknowledging that, in a lot of groups, this did allow of, having broader links because, organizations tend, if not working in silos as a result of the funding, but also maybe in terms of constituencies. And so this allowed for a little bit more, cross-movement building and ensuring that there is a common consensus with regards to the state of health in our context. And I think, in adopting this feminist approach really reflected the inclusion around migrant communities, ethnic minorities, indigenous folks, LGBTIQ individuals, and other, intersectional communities. And I think, just to address the aspect around accountability, the impact of VNR reporting is yet to be determined. And, I think feminists have been questioning, trying to figure out, how meaningful can the outcomes of the VNR processes be at a country level. And I think this is where it's helpful in coming from, other sort of advocacy experiences. So looking at just how binding instruments such as the UPR, Universal Periodic Review, the Committee on the Elimination of Discrimination Against Women, the African Peer Review Mechanism, are all, critical sort of elements that really do allow for social participation and actually challenging the government in terms of what they present in their own state reports. And I think, this consultation really did provide an opportunity or a baseline at least to ensure that, this is the same information that we can utilize within that context. And, there were key sort of milestone opportunities that were quite unique. The first is that, it was the first time that the Ministry of Finance opened up to civil society and the public overall to contribute towards the state budget. And then the second was the constitutional review process, where we were able to present and field aspects around mental health, around primary health care, and UHC, acknowledging the fact that the country does not ensure the right to health in its constitution. And one of the reasons why I mention this is because there are opportunities in looking forward and towards the HLM for 2023, basically the three HLMs, actually, if I can put it that way, because we've got the CSW, the HLPF, and the Water Forum are coming, which I think at a global level are quite key, in being able to at least create linkages and ensure that there is momentum and there are continuous conversations around health, and also noting that at a country level at least, there are committees, like child protection committees, gender machinery, that can be mechanisms for social participation, along with technical working groups under Global Fund architecture or Minister of Health and Wellness, community health referral services. And so I think it's really quite important, in being able to link a lot of these, because the information is quite the same. The stakeholders are the same in many instances. And so it provides a nice opportunity to be able to sort of ensure that the consultations aren't just in isolation or aren't just, specific to UHC, but that there can be links to many of these other national, regional, and international mechanisms.
Thanks so much, Dumi, for that really clear explanation of sharing of the consultation, but also, very strategic and concrete actions and issues we should consider in terms of looking forward to next year's HLM. So let me, so I want to, before I wrap up my moderation, I want to once again thanks all my panelists for bearing with me today and for sharing, for bearing with me in terms of the time management, but also for sharing your experience and your findings with us today. I'm going to turn the floor back over to Karthi to introduce our last moderator for our session. And again, please leave your questions and comments in the chat, and we'll be coming back to those in a little bit. Over to you, Karthi.
Thank you so much, Jen. Thank you for bearing with us and the technical challenges we've had today. It is my pleasure to welcome our next moderator, Dr. Lasha Gogoatse, is the technical focal point for programs related to health and migration, drug abuse, HIV, and tuberculosis in the Health and Care Department of the International Federation of Red Cross and Red Crescent Societies. He has spent several years as the Federation's field delegate in Europe and Asia, He also coordinates activities of Red Cross and Red Crescent Health and Migration Working Group and the Red Cross and Red Crescent Partnership on Substance Abuse. We've had the pleasure of working with Lasha on the country consultations from its inception, from developing the methodology to implementing it this year in IFRC-led countries like Italy, Switzerland, Jordan, and Eswatini. Thank you so much, Lasha, for joining us here today.
Thank you very much, Karti. And I don't know, I don't see myself in the screen. I don't know if I'm seen there. So I don't know this technology also. I don't know how it works. So it's extremely my pleasure to be part of this discussion and also the consultation. So actually, I really would like to mention that with Jennifer, the country consultations, we started to prepare the high-level meeting on tuberculosis in 2017. So, and this is really extremely useful to bring the voices of the community and civil society. Jen, you agree on this, and so then we continue with the lessons learned from this consultation to the country consultations on UHC agenda. So as Karti mentioned, I represent the International Federation of Red Cross Red Crescent Societies. This is the world's largest humanitarian organization with 192 member national Red Cross and Red Crescent societies. So we are really pleased to be part of the member of the CSCM, and also CSCM is fascinating constituency. It brings together civil society, community organizations, and non-governmental organizations, some of the international organizations. That I think that's really the tool to strengthen each other's voice. So as Kati mentioned, we did the consultation this year. Also in not resource limited countries. I think this is also very important. I will not repeat the findings because they were well summarized in the first presentation, as well as by the distinguished colleagues from different countries. I just would like to mention that it's not only this is the issue and this is the problem for every country. So where health system is working better than somewhere else, where the insurance system is working better than somewhere else, there are still groups of the communities that need to be better reached. And one additional comment that I would like to make, the role of the care providers, role of the community healthcare workers, and role of the community health volunteers in really improving access to the health services and importance in investing in them. So being auxiliary to the national authorities, Red Cross, Red Crescent societies really serve as a bridge between the communities and the governments. And so I hope that we will continue working together. So, okay, I finish here. So I move to my main task related to the questions and answers. We have some time. So how much time we can have, Karti? 10 minutes, maybe? So please ask the questions to each speaker or bring the comments. So I just follow the chat. So we have very interesting and useful comments from Gabon, from Marie-Laure. It's concrete suggestions related to the advocacy and ask to the governments. We have really extremely important question or comment related to the decriminalization of the suicide concretely. So whether anyone wants to elaborate on this, or so we can keep this as a comment and really respond afterwards. So now, if any of from the audience, anyone has a question.
Est-ce que je
Lasha,
peux
there are two
intervenir sur le
questions in
cas
the
de Marie
Q&A
du Gabon?
function. I'm not, but they need to be translated. They're in
I
French.
translated, that's what
Oui,
I'm saying. So this is the
Marie du
concrete.
Gabon a proposé
Okay.
par rapport aux
I think
organisations
we
de santé
have to,
communautaire.
I think when one people is
Okay.
talking, another one, maybe we can keep silent. So basically the question, as I mentioned, the question is from Gabon, from Marie Laura. So basically this is the suggestions. This is not the question. This is suggestion.
C'est une suggestion que je peux
Thank you.
un peu compléter. C'est-à-dire que le problème, ce n'est pas de mettre en place. Le problème est que c'est le suivi et qu'au niveau de santé communautaire, qu'il faut que l'État participe à l'équipement aux ressources humaines et à la qualité des prestations. C'est ça qui pose problème. Les structures sont là, mais malheureusement, c'est pour cela qu'il faut. Nous, on a proposé de faire le financement des structures de santé par l'État. Le problème, ce n'est pas de créer, mais le problème, c'est de soutenir avec la communauté, bien sûr. C'est ça que je voulais lui dire. Merci.
Yeah, thank you very much. This is very important point. I just want to reiterate what the message from Marie-Laure. We got suggestions, offers related to the better engagement with the government. So ask governments to develop community health policies for those who do not have it, and most importantly, implement those policies. Government include specific budget lines to allocate funding to specifically for community health in the finance law, accountability between civil society and the government, establish the community monitoring system for the management of financial resources and implementation of activities, and the civil society to be well represented in the decision-making bodies. So just really to mention that accountability and responsibility remains the highly recommended issues to the governments. So I mean, these are all important points, and I think those are very valid recommendations to include into our recommendations as a next step. So that's the comment from Marie-Laure. If anyone wants to comment it. And the second or first comment, it was about the decriminalization of the suicide is something that needs to be to have the broader attention. So in more than 20 countries, this is the issue. And so the Jordan recently re-examined how do suicide survivors access to healthcare services and if they are facing incarceration or not. So I think so those comments I read there. So if I don't know if I missed anything. Yeah, and also the question related how the Mental Health Alliance work and what is the role of ensuring the universal health coverage. So how the advocacy to the government is going on. So we have these three main points, and if any of the panelists would like to comment on those points to start with.
Moi, je voulais faire des commentaires par rapport à l'insécurité. Bonjour, comment vous faites avec l'insécurité? Si vous permettez, bien sûr.
Sure. Absolutely. Floor is yours.
Ok, donc, je ne vous apprends rien, le Mali est dans la sécurité depuis 2012, mais depuis 2012 jusqu'à maintenant, les centres de santé communautaires fonctionnent au niveau des communautés. La simple raison est que les associations de santé communautaire sont mises en place par la communauté même. Donc, ce sont les communautés qui vivent dans ces zones. Donc, même avec l'insécurité, le travail continue au niveau des structures de santé. Donc, c'est pour vous dire que l'insécurité, si la communauté s'implique dans le travail, donc il n'y aura pas de problème. Donc, depuis 2012 jusqu'à maintenant, la présence de l'État est compromise dans certaines localités. Mais avec tout ça, les structures de santé fonctionnent à travers les centres de santé communautaires gérés par les associations de santé communautaires et qui s'occupent des paquets minimums d'activités dans ces zones. Donc, pour moi, l'insécurité n'est pas un handicap, mais il faut que la communauté s'investisse dans leurs problèmes de santé. C'est ça que je voulais donner comme commentaire. Merci.
Thank you very much. Marie-Laure, you would like to comment briefly, and then we have the Gustave.
Oui, merci beaucoup. Bonjour tout le monde. Non, c'était juste pour rebondir sur l'intervention de mon frère du Mali, pour lui dire que les recommandations faites par le Gabon ne sont pas agressées au Mali. Là, on a bien écouté l'expérience du Mali qui est bonne, mais je pense que quand on fait les recommandations, on peut se mettre dans notre contexte à nous. Et c'est une façon de présenter un peu notre situation aussi. Donc, on prouve que ce qu'on a fait là, c'est bon. Ce n'est pas spécifiquement au Mali que je m'adressais. C'est à tous ceux qui peuvent se reconnaître. Merci beaucoup.
Thank you very much, Peter. Very brief comment to Gustav. Sorry, very brief comment from you, because we need we don't have more time.
Very well, thank you. So briefly to say that the Alliance is a group of organizations that are focusing on mental health and disability. And it is just one way of cross-fertilizing our experiences and best practices for collective advocacy. Yes, we do engage with government, and we use any opportunity to articulate what we pick from our engagements with communities in the field and bringing to bear perspective of persons.
Thank you very much. Thank you very much. And also, I think so you shared your website. Maybe you can share this, and people who are interested to contact you. So now also we have to finish, and I am passing to Vaisva, coordinator of the CSM Secretariat, for the final words related to the UHC Day and the roadmap towards UHC-HLM. Vaisva, floor is yours.
Thanks, Lash. Great. Thank you all for being with us all this time. I'm going to quickly go through some of these activities for UHC Day and also touch on the road to UHC high-level meeting on UHC. So this UHC Day is very important, as some of the speakers have mentioned, because of the UN high-level meeting on UHC coming up in September 2023. I will talk about it in a second, but first I want to draw your attention to some of the ways that you can take action on UHC Day this coming Monday. We ask you to ask or call your leaders to act on their commitments to UHC by using some of the messaging that we've put together and that we have shared in different emails, and I will share the links here in a little bit. You can also take action by familiarizing yourself. By familiarizing yourself with the state of the UHC commitments and the data on your country. At the beginning of this webinar, we had Akihito from UHC 2030 present some of that information, and you can see it there on the website. You can write a letter to a decision maker and ask them to commit to participating in the HLM on UHC next year. You can also help amplify by telling the world why health for all matters, and also by sharing on social media and answering the question on how can we build a healthier future for all. You can also act by joining the virtual rally on Monday. We'll have a webinar and hear from speakers from all over the world on how we can build a health future for all. There are many, many opportunities to participate and engage in this World UHC Day next week. But before we close, I wanted also, next slide. I also wanted to let you know that it is time to get ready for the UN high-level meeting on UHC next year to put our progress on UHC back on track. The high-level meeting will happen in September, and preparations are already underway to ensure that it's not just successful in terms of having many high-level leaders, world leaders attend the meeting, but also that when they come to New York next year, that they commit to taking bold and ambitious actions to deliver on UHC for their people. For the UHC movement, the broader UHC movement and civil society, the process begins now. The UHC 2030 has launched a task force that is putting together a plan for a multi-stakeholder engagement. And as a first step, they are currently reviewing, doing analysis of the previous key asks that you can see up here, and some of the gaps in implementing the political declaration on UHC from 2019. The top key asks that you see on the screen were developed in the lead up to, by the UHC movement in the lead up to the 2019 high-level meeting. And the two more at the bottom were added after that. And the task force is reviewing all of this and is developing a framework for all stakeholders to feed into beginning in January. We'll be coming to you, CSM will be coming to you with more information about what that process is going to look like. Next slide, please. And this is a provisional timeline of key events and moments toward HLM next year. We, as I said, right now we're at analysis, the review of the key asks done by the UHC 2030, and then there will be a multi-stakeholder survey that is expected to be released around early January. And civil society will have an opportunity to feed into this process. And then after that, as you can see here, we will have your feedback collated and then reviewed and integrated into the framework we have. And in around March, we expect to have those key asks finalized. And then we'll have a multi-stakeholder hearing sometime between April and May, and the process goes on and on through September. More activities are expected at the regional and country levels, and we're already having conversations with some of the actors at the regional level, like UPCASO, like Work Health, on how we're going to engage civil society in those spaces as well to participate in this process. So please be on the lookout for information from us. We will continually provide guidance and information on where activities are happening, when they're happening, and how you can get involved. This is a very, very exciting time, and I want to thank all of you for joining us today. And especially I want to thank our fantastic presenters and moderators and interpreters for a great discussion and insights on the state of the UHC commitments around the world, and really encouraging you to focus on, all of us to focus on building the world that we want and the health future for all. Thank you so much. Kathy, over to you.
Thank you so much, Faisal, and thank you to everyone who joined today. I have been busy putting links in the chat box of many of the resources we talked about today. Please feel free to reach out to us if you have any questions or would like to be involved in more of these activities. Our email address is csem@msh.org. And if you go to cscemonline.net, you should find a link to join the CSCM and stay in touch, especially as we begin this important advocacy year to 2023. Thank you all for joining and see you next time.